Welcome everybody to the dialogue on quality, equity, inclusiveness in urban healthcare delivery. Joining us today is Dr. Aqsa Shaikh. She is an associate professor of community medicine and nodal officer for the COVID vaccination center at the Hamdard Institute of Medical Sciences and Research, Jamia Hamdard, Delhi. She is one of the India's first transgender doctors and a proud advocate for transgender rights. She is also involved in the I Hear initiative at Sangat, India, which focuses on including the transgender and disability communities in the healthcare sector. She is the founder and director of the Human Solidarity Foundation and a vocal advocate for rights-based gender justice for transgender people, people with disabilities, and people with mental illness. Dr. Shaikh has been recognized for her work in mental health, receiving the Youth Ki Awaaz Award. Dr. Shaikh is interested in medical ethics, the humanities, and medical education technology. Dr. Shaikh, we would like to congratulate you first on managing one of the busiest urban COVID vaccination centers at Hamdard Institute of Medical Sciences and Research, Community Medicine Department. Kindly reflect on the planning, management, and personal satisfaction of the experience. Let us begin by asking you about some of the unique features you have adopted in managing the center and other reflections on making this center user-friendly for marginalized population. Also, please highlight any awareness campaign activities that you have undertook for the center.
Thanks, Deepika, for having me for this very vital conversation on my experience around managing a COVID-19 vaccination center in Delhi. So I remember it was 16th of January 2021 when we first started the COVID-19 vaccination program in India and also in Delhi on the same date. And our center was also opened on the same date. We need to kind of go back and understand the situation in which vaccination was launched in India. We were in the middle of the pandemic. People were dying. We had no cure available. And at that point of time, the only hope that we received was getting an effective COVID-19 vaccination. And especially in the first phase, if you remember, it was started for the healthcare providers. And at that point of time, it really came as a glimmer of hope for those who are trying to save lives of others, that finally we may have something that can protect us from this virus that we really don't understand. It was in that environment that the vaccination center was launched. But at the same time, there was also, I would say, concerns about the effectiveness and the safety of the vaccine by the healthcare workers, because it was a new antigen which was being launched. Some of the vaccines at that point of time were not fully approved for use. They were only allowed for use in the trial conditions as an emergency provision. And therefore, there were a lot of healthcare workers who had concerns about taking vaccination, and the government had literally mandated that the healthcare workers first take the vaccines to build the trust and confidence amongst the masses. So it was in that scenario that the vaccination was launched, and I was very blessed to get the opportunity to manage this vaccination center, not just as a community medicine person, but also as a transgender person. I took it as an opportunity to ensure that this service is made a quality service and a very inclusive service. And when it comes to quality and making a service inclusive, I think one very important aspect is to ensure that it is technically correct, that it is scientifically valid. So the first thing that we did was to ensure that we had a safety net cast wide. We had developed an ICU bed as an AEFI facility, adverse events following immunization, within the vaccination center. We ensured that the vaccination center was not in the hospital but in the college building, because in the same hospital building there were COVID-19 patients and many people were afraid of going to the hospital building for getting the vaccination. We ensured that the protocol, for example, of allowing people to be observed for 30 minutes post vaccination is followed for everyone, even if they happen to be the dean of the hospital and extremely busy. So these important steps in the quality assurance were followed, so that we do not compromise on the quality and the medical aspects. I remember we had very interesting drills on how to manage AEFI, and we undertook certain provisions to ensure that people were confident that if I take this vaccine and if anything happens to me, then I will be in good hands. So we ensured that we had a dedicated lift for the patients and for taking AEFI. Ramps were opened up. There was a dedicated ambulance, and the path for the ambulance to reach the hospital was always kept open and clear. So these important measures were done so that, first of all, our healthcare workers get confidence in not just the vaccine but also in the process of vaccination and managing the adverse events following immunization. Once all those things were in place, then at that point of time there was a lot of environment of fear, apprehension, uncertainty, and we wanted this vaccination process to be a celebration, to be a very joyful experience, of celebrating the human innovation, celebrating that we are finally getting some breakthrough in our struggle against COVID-19. And therefore the entire vaccination center, right from the entry, the waiting room, the vaccination area, and then the post-vaccination observation area, was decorated in a way that it celebrated the process of vaccination, because people had to spend a couple of hours from the entry to the exit, and we wanted that experience to be joyful, peaceful. People were bringing their children to the vaccination center. They were coming with elderly who were also wheelchair users, and we wanted that it should be a comfortable experience. That was the first time I remember when we ensured that there was a unisex toilet in the university, and for a very long period of time that was the only unisex toilet in the university, the first and the only. Ramps were opened up, cleared of all the obstacles. Many times in our infrastructure we do have ramps, but when a person actually wants to use them, there are obstacles around, there are flower pots kept around, and they're not open sometimes. So we ensured that these structures are not just existing, but they were also functional, and special provisions were made for that. We had kept selfie booths. Also videos were on for people to enjoy and relax, because we had seen that there was a lot of anxiety when a person came to take vaccination, and we wanted it to be a very joyful experience.
Right. Very well said, ma'am. And my second context was related to innovation strategies only. And you very well mentioned how you started decorating the areas from where the people were traveling, so that to provide them a very good experience for the vaccinations. So now I would like to draw your attention to more few innovative strategies that urban primary healthcare centers can adopt, particularly around social mobilization and building trust and confidence in the community. These strategies address some common barriers to getting COVID-19 vaccination. These barriers may include structural, behavioral, or informational too. They involve fostering strong relationships and partnerships with trusted organizations and communicating responsibly, which are fundamental to any strategy for establishing trust within the community. So, we would like to hear your thoughts on these innovative strategies and how they might be applicable to your work at the vaccination center. And we would also like to learn about any other innovative approach that you have adopted.
So, When we speak about vaccination process, it's not just about one particular center, and it's a multi-pronged approach to get a person to accept vaccination and to get vaccinated. And especially when we have clients who come from marginalized populations, be they from the transgender and intersex community, whether they are persons with disability, or elderly, or people with mental illnesses, or even women who are pregnant, for example. We have to ensure that the vaccines are acceptable to them. They have trust in the product and they have trust in the process of the vaccination also, and that was something that we had to work on, especially in the initial phase of the vaccination process. So the first thing was, as I mentioned, about the infrastructure and ensuring the infrastructure was accessible, it was friendly, it was comforting to people. But another important issue is, what about those people who have not yet come to the vaccination center? How do we get them to come? And especially speaking of my experience with the transgender community, there were issues of lack of information, or lack of correct information, I would say. There were many questions that were unanswered, like if the vaccination had been tested on transgender people, or had it been only tested on cisgender people? Does the vaccine interact with the hormones that a transgender person may be taking? Are there any documentations of adverse events that specifically occur in transgender people? Is it safe to take vaccination during the surgical transition phase, since some of them were about to get operated or had gotten operated, and we had heard about coagulation related adverse events happening? Then there were also questions about the process of vaccination. There are some transgender persons whose legal name may not match with the name that they are currently using. Their legal gender may be different from the gender that they identify with. Then if they come to the vaccination center, they have to register with the CoWIN app. How do they do that? Will they get their certificate in the old name and old gender, or they can choose the new name and gender? What about the sex being written on the certificate? Will it be written as others? Because a lot of transgender people have problem with the use of the word other, because it otherizes them into something else. And then there were also issues about how they will be treated at the vaccination center, for the queue to reach the vaccination center, while they are waiting in the vaccination center. There were questions about whether the healthcare workers will understand who they are, or will they ask unnecessary questions. Will the guard at the vaccination center, the civil defense volunteers, the nurses, will they be cooperative, respectful, or will they face stigma and discrimination at the vaccination center also? So there were a lot of questions and anxieties that a potential transgender client had, and we try to work over them by asking prominent transgender persons, who have a say in their community, to come and get vaccination. Because once they get vaccinated, then they become ambassadors for our vaccination program, and we celebrated that by posting it on Facebook, Instagram, that for example, Abhina has come and taken vaccination. We also did a lot of online programs, especially with the CBOs, and ensuring that the transgender people who do not have access to a lot of scientific information attend this. So that they get proper information, and I would say truthful information. Like, for example, saying them that the vaccination is safe, 100% safe, would not be the right answer. So we said that this is the information that we have and this is the information that we don't have. We were very honest in saying that the vaccines were not specifically tested in transgender people or on trans people who are on hormone replacement therapy, but that we expect that the benefits of this vaccination will outdo the risks that we can anticipate. So this clear, honest communication can help building trust in people in vaccination, rather than saying that it's 100% safe, it's 100% effective, and nothing is going to happen. So that was something that was built in the process of the vaccination. And I think one very important thing that we did was we made it a very model center for vaccination for queer folks. So there were many people I remember who were not near a hospital, who would travel to like 15-20 kilometers just to come to this vaccination center, because they knew that the nodal officer is a transgender woman herself. And that gave them trust, that I will be respected over there, that I will not be discriminated. And I think that signifies the importance of having the community involved in the process of delivering the vaccine. Rather than looking at them as only recipients of a service, we need to see how the marginalized communities can become the providers of this service, because then that takes the trust to a very high level. And that's what we did with this process. So that was another innovative thing that we did in building the trust. And also we were always hesitant to use the word vaccine hesitancy, because when you say vaccine hesitancy, you are putting the onus on the recipient of the vaccine, that everything is perfect, why are you hesitant in taking the vaccine? But rather we always looked at vaccine trust and vaccine acceptance, and honestly looking at what are the barriers because of which people are not able to access vaccination. Like for example, when it came to elderly, we had a lot of demands from elderly that we want home vaccination, that it is just not possible for someone to bring a 90-year-old woman to the vaccination center. Unfortunately, we didn't have permissions to do that, but we tried that if we could take certain measures by which we can ease that process. So I remember our vaccination center was on the 3rd floor, and we were like, if you can just get the person to the ground floor, then our nurse will come to the ground floor, we'll give the vaccination, we'll carry a tablet on which the CoWIN app can be opened and we can do the verification, so that the the journey to the vaccination center can be shortened. We can do observation in the ambulance while they are being seated over there. So these kind of, I would say, going a little extra mile, to ensure that every person gets vaccinated. Because while we were looking at numbers that, oh, we got 100 people vaccinated, 200 people vaccinated, these numbers often hide the fact that the people who are not getting vaccinated are mostly marginalized. For us, the success story was getting one woman of 90-year-old getting vaccinated rather than 10 able-bodied adults getting vaccinated. So while in vaccination numbers matter, it's also important to ensure that we reach out to the people who otherwise would have been left out of the vaccination process. And I would always say this, that it was a teamwork. We had great support from our administration, from the government authorities at the district level, and also from, I would say, my younger team members, right from nurses to ward boys to the civil defense volunteers who acted as security guards. So it ultimately, I always felt that my role as a nodal officer was also as an HR manager, to ensure that this team does not get fatigued, does not get demotivated, and celebrates things like, oh, we had a 90-year-old one vaccinated, we had a transgender person come to our vaccination center, rather than only looking at numbers of 100, 200 being done.
Very well answered, Dr. Aqsa. As you brought your focus towards marginalized communities, I would like to shift your focus towards the mental illness of these population segments. So, people with disabilities faced unique challenges during the pandemic, as we know, and they included increased isolation, difficulty in assessing the healthcare, and also increased anxiety and depression. Despite the increased need for mental health services, the delivery of mental health care in India remains suboptimal. According to Forbes India Report 23, only 10% of people with mental health issues in India receive treatment. We have been hearing from mental health practitioners that long COVID sequels significantly impact people's mental health. In light of suboptimal mental health awareness and delivery care, what steps could governments, communities, and family members take, particularly for the elderly, those with the disabilities, and the transgender population?
You have raised a very crucial question with reference to the mental health, and especially about the marginalized communities and in the wake of the COVID-19 pandemic. So we need to understand that mental health is something which is a need of everyone. Probably I think everyone at some stage of their life may need a mental health care service. And pandemic or no pandemic, the demand for the mental health services, the need for the mental health care services is huge. Add to that the layer of the pandemic, the layer of the measures that were taken in the pandemic, like nationwide lockdown, working from home, schools being shut for a very long period of time, losing your near and dear ones to COVID-19. All of that had added immense toll to the existing, baseline level of mental health need that we have. And the pandemic also led to a decrease in the provision of mental health care services. I would say also reprioritizing infectious diseases over the NCDs and the mental health diseases. And in such a scenario, when now we speak about marginalized populations who even in the ordinary times do not get access to mental health care services, during pandemic they have an increased need but now lesser supply. And therefore they suffer the most. In fact, one of the research projects that we did at IHER initiative was to look at how the transgender community navigated healthcare during the COVID-19 pandemic and how that had an impact on their mental health care. And our findings from that study was that even before the COVID-19 pandemic, a lot of transgender people found it difficult to access basic healthcare services, like just going to an OPD for fever or cough. And with the pandemic, those basic healthcare services were also not available. And we also know that trans people have a higher need of mental health care services because of the additional stressors that they undergo. And even in the ordinary times, they have a lot of unmet needs of mental health care, and that only increased during the time of the pandemic. And a lot of this increase was also because of the violence that was taking place in their biological families. A lot of queer folks, and especially trans people, do not stay with their biological families, but during the pandemic they were pushed back to the families because they had no choice. They do face a lot of physical, emotional, and even sexual violence within their own homes, which also includes conversion therapy to try and change their gender identity and sexual orientation by medical and non-medical means. It also included forced marriages, preventing their access to social media, or just meeting friends and expressing themselves in the form of gender expression of their choice. And all that had a great toll on their mental health. Similarly, when it comes to other communities, be it women, be it persons with disability or elderly, again the magnitude of mental health care needs only increased. But when it comes to the provision side, we had seen that a lot of hospitals had become dedicated COVID-19 hospitals. The psychiatry OPD, which was considered to be not a very essential service, was either shut down or psychiatrists were working from home during that point of time. Some of the psychiatry residents were posted in COVID-19 ICUs and they could not be there in the hospital. And I think it hit us a little later during the second wave, when the healthcare workers now started to suffer from mental health care issues. They were seeing death every day, they were seeing hopelessness, and especially during the time when the oxygen supply was very less in places like Delhi. I remember in my own hospital, I used to speak to the healthcare workers and they would like, I'm feeling so helpless, that all my medical skills are useless if I do not have oxygen supply. They were battling with the dilemma of whose oxygen flow to increase and whose oxygen flow to decrease. They were seeing patients gasping in front of them, but they couldn't increase their flow of oxygen. We were waiting that, okay, the oxygen tank is coming, it's 5 kilometers away, it will reach, but our supply may end. And we have seen healthcare professionals themselves, die of lack of oxygen allegedly. Officially, of course, no one died of lack of oxygen supply. And in that scenario, we had started this service of providing tele-mental healthcare counseling to doctors first, and later on to people who were facing grief because of the people who had passed away. And I remember from those incidents that there were some doctors who had lost multiple family members. There were doctors who wouldn't go back home for weeks. They would stay in the hotels because they didn't want their young children to get COVID-19. There were doctors, who were suffering from COVID while they were being pregnant and still going on the duty. So, there are immense stories of human struggle and suffering on the mental health front, and also how we failed them in supporting at that point of time. We call them COVID-19 heroes or COVID-19 warriors. But when it comes to the mental health of warriors or healthcare workers, we know that they are the groups who often suffer the most, but then are not able to access services. So that's something that we really need to work upon.
Right. So all your experiences, Dr. Aqsa, have been very eye-opening and thought-provoking. So I would like you to please provide us a very brief conclusion. How would you like to conclude this conversation today?
I think, while we speak about urban health today in the context and with the background of COVID-19, in the background of providing vaccination, we need to understand that this was not the first pandemic, and this is not going to be the last pandemic. We will have such public health emergencies of international concern keep coming and challenging our healthcare systems. And therefore, it's important to go back to the basics of universal healthcare, to the basics of primary healthcare, and ensure that healthcare is provided to everyone, and especially to those who are marginalized on account of age, gender, sex, social class, migration status, or ability or disability. Because when we speak about universal healthcare, it's not only about reaching 100% in terms of quantitative coverage, but ensuring that especially it reaches everyone who otherwise would not have been able to receive the service. And that needs strengthening our primary healthcare services, strengthening our healthcare delivery, ensuring that the marginalized communities are involved in the process of planning, delivering, and later on evaluating our healthcare services. And finally, in understanding that every life matters, irrespective of whether they're an able-bodied person or a disabled person, a cisgender person or a transgender person.
So thank you so much, Dr. Aqsa. We assure you that this will be an ongoing conversation. We are going to invite any query or any other doubt that our Indian citizens would be having, and we would like to hear from you again. And thank you so much for engaging in this wonderful dialogue on quality, equity, and inclusiveness in urban public healthcare delivery. Thank you so much.
Thanks, Deepika, and it was my pleasure to be here.
Hello, fellow citizens. We have just heard Dr. Aqsa Shaikh. During the COVID times, Dr. Aqsa Shaikh managed one of the most successful COVID vaccination centers in Delhi. I and my wife got vaccinated from that center, so I speak from experience. This session is very important for the citizens of India to hear, to understand the core of quality, equity, and inclusiveness in healthcare. But it is also a great lesson for public health students, because after all, Dr. Shaikh is a professor and she teaches public health. She talks about vaccine hesitancy, and she says that vaccine hesitancy is an unacceptable term in today's times, because with vaccine hesitancy, the onus somehow is placed on the community and those who are receiving the vaccine. It should be the other way around. The onus should lie with us, those who are engaged in public health policy making, in designing programs, and in delivering programs. Because we will have to build the confidence within the community by ensuring that the awareness, the access, and the acceptability of the vaccine is addressed. We also address the apprehensions that the community has. We will have to build trust. She demystifies what access means. Access has multiple components. One is around the confidence building, it is around the infrastructure, and it is around a trusted relationship between the community and the service provider. In this session, there are 4 key messages that we hear from Dr. Shaikh. The first is that vaccination rhymes with celebration. Vaccination is a celebration of life. But in order for it to be celebratory, we will have to share information transparently and truthfully with our communities. The second part that she talks about is about teamwork. The teamwork between governments, non-government players, academic institutions, and most importantly, the citizens of India. All will have to come together in an environment where they trust each other and take the program forward. The third thing that she talks about is how at the center that she was managing at the Hamdard Institute of Medicine and Research, HIMSR, how they had built convenience systems. For example, just to build confidence that in case any event happens after vaccination, they not only followed all the protocols and guidelines that the government had, but to add an extra layer of assurance, they had dedicated one elevator just for any emergency that might arise. They had opened up ramps and had dedicated ambulances in case any case needs to be referred. These measures go a long way in building assurance and confidence within the community to accept vaccines. But the final thing that she says, and is the most important and fundamental of the initiative that we are working on, the QEI, the Quality, Equity and Inclusiveness Initiative, is about the value of every life. That is the motto and the crux of our initiative. Every life matters. Celebrations of coverage must continue as we are celebrating the 2 billion plus doses that have been delivered of COVID vaccine, as we celebrate our routine immunization and our other public health programs. But we must also take into account the lives that remain somewhere in some corner of India and are not included in the celebration. As we said, every life matters. And unless every life is reached, every life is covered with the health services they deserve, we will continue to celebrate, but keep our watch that no one is left out. Every life matters. Thank you, Dr. Aqsa, for reminding us of the fundamentals of public health once again. Thank you.